Okay, welcome back. I think we might start a little bit early because I have a lot of material to get through. Whenever I do these webinars, I find that it's sometimes a little challenging to get through all the information that I dig up on the topic. So I think we'll get started. I want to thank everyone for joining me today. So obviously the topic is on laser therapy for wrist sprains and fractures. For those of you who don't know me, my name is Dr. David Kunashko. I'm a chiropractor by profession, also trained in acupuncture, and I've been practicing for, I guess, 30 years now. And I've been involved with low-level laser therapy or photobiomodulation for over a decade now. My background is from the University of Toronto in molecular biology and molecular genetics, where I did undergrad and postgraduate work. So I've been working in the clinic here in Toronto, as well as now the medical director for the company. And so I'd like to just remind everyone that these webinars are recorded. And once we edit them, we will send out an email with the link to watch it again. Most of you should receive that link, but for some reason, if you don't, you can always email me and I'll send that out. It usually takes about a week or less to get that out to you as well. So that's essentially how these webinars work. I do two different types of webinars. I, generally speaking, will do one geared more towards healthcare professionals, like the one today. So the level of information and I guess detail is geared towards healthcare professionals. Not that a non-healthcare professional can't get a lot out of it. It's just obviously the anatomy and some of the other topics might be not necessarily, you may not have known that or whatever. And I also do a personal therapy system webinar more geared towards the general public for using our consumer devices, and obviously not quite as technical. So today's is on wrist sprains and fractures. So I will talk a bit about the anatomy and etiology and epidemiology of both wrist sprains and fractures, and just offer a couple of bits of photobiomodulation research on those topics. And then I'll talk a little bit about how photobiomodulation can actually help heal, whether it's a fracture or a ligament injury. And then I'll talk a bit about obviously using BioFlex and how you might approach it. Again, this is geared towards professional equipment, so using a class 3B laser probe. Those of you who might be listening in that have the BioFlex personal therapy system, some of this is relevant, but as far as a probe goes, you don't have that, so that portion wouldn't be overly relevant. And I always have time for Q&A at the end. You can always type in your questions as they go along. Try to make them relevant to the topic for today, because that's kind of what I'm doing here. But if you want me to do another webinar on different topics, I'm more than willing to hear what you might recommend as well. So let's dig into a little bit about the anatomy. This is a review for everyone, I'm sure, but it's been a while maybe since you've looked at all the different ligaments. There's actually 20 ligaments that are in the wrist area. So these are connecting carpal bones to carpal bones, or carpal bones to the radioulnar joint as well. So that's like sort of the wrist complex that we're interested in talking about today. And there's so many ligaments there, you would kind of start to be a little like overwhelmed with the potential for injuries. But I guess fortunately, but unfortunately, when these injuries occur, they tend to occur and affect just a couple of ligaments or bones most commonly. So that's what I'm going to focus on today specifically. So when we look at this is now the dorsal view of the palmar, not dorsal, the palmar. I'll use the term volar instead of palmar, or dorsal. But the palmar view of this, you can see there's two specific areas that I'm going to focus on today, between the scaphoid and the lunate, and then between the radioulnar joint and the lunate and triquetrum as well. So those are the areas that tend to be most involved. So if you look at the dorsal aspect of the wrist, there's an area that's commonly referred to as the tricartilage compartment area. So this area has ligaments and a piece of cartilage that is really prominently important for function of the wrist joint. In this area, sometimes called the TFCC area, is commonly involved in injuries, as well as a ligament between the scaphoid and the lunate, specifically the scapholunate ligament. So these are the structures that tend to be more commonly involved in wrist sprains. So obviously a wrist sprain is when the ligament is pathologically stretched, twisted, or lacerated or torn. And, usually it involves sudden application of force. So, sudden loading, like during a fall or twisting injury, that kind of thing. Most commonly it's when someone's fallen in a sport, or, you slip and fall, or in the elderly where they have balance issues and they fall on their hand. So it's usually the outstretched hand where the wrist is extended. Obviously, that tends to be the most common mechanism of how it actually occurs. Now, in severe cases, the tear can be quite large, and it can cause a lot of instability. And in those cases, it may in fact require surgery. So again, the two most common ligament or areas of the wrist with respect to ligament injuries is a scapholunate ligament. This is in the middle of the wrist between the scaphoid and the lunate bones. And I'm showing you a couple of different views of where that's located. This is really important, because when you're going to assess and you're trying to diagnose the problem, and then when you're trying to treat it, you really want to know and focus in with the equipment on that ligament that's injured, right? So, you may have imaging, but most of the time you don't have imaging. So you're going to be doing it through palpation and through examination to really determine what structures are affected. And then earlier I mentioned that TFCC, or the triangular fibrocartilage complex. This is on the junction where the radius and the ulnar meet together with the carpal bones. It's a complex because it's a couple of ligaments as well as a piece of fibrocartilage. And this is a really common problem, and it leads to a lot of difficulties with healing because cartilage is involved. That's just another view of what it looks like. You can see the ligament there. And then it's hard to see, but there's this hunk of cartilage, kind of like a triangular in a sort of a pyramid triangle shape deep to that ligament. So as I mentioned, they usually occur, in athletes, or it can occur, slip and falls or work, or it's such a common problem. I was looking up the stats, I didn't put them here, but apparently it's like up to 20% or so of orthopedic consultations in hospitals are from wrist injuries. So, these things happen all the time, which is kind of why I want to do a webinar on it. So the injury to the scapholunate ligament is the most common injury, and it's the most common form of carpal or wrist bone instability. Again, hyperextension is usually the most common mechanism of injury. The second most common is probably the TFCC, which is that triangular fibrocartilage compartment. Now, this is usually associated with forced axial loading or distracted of the volar forearm and wrist, with usually repetitive movements involving extension and flexion, or even supination, pronation, or ulnar radial deviation. So think of using a jackhammer, or a lot of different things that construction workers do, or you may even do around the house, and you apply too much force as you're loading up on the wrist and then twisting it. That's when this type of injury usually occurs. So when you're doing your examination of your patient, a history is critical, right? Because if you do a good history, it just backs up your findings for your exam. You kind of already know what's going on with your good history. So make sure you're asking about the mechanism of injury, because that will oftentimes give you some indication as to probably what the issue is. So the TFCC, or the triangular fibrocartilage, you see I have some pictures here. I'll try and get my photo out of the way here. Pictures of this complex. So essentially this is at the distal radial ulnar joint, or the DRUJ, is held in place by two ligaments, the radial ulnar and the ulnocarpal ligaments. Now, the primary purpose of this structure is to provide stability at this particular juncture of the wrist. And it allows it, especially with the cartilage, to withstand compressive forces. That's why that cartilage is there, to prevent injury when you have this cartilage. And again, as I mentioned earlier, it's usually happening with it could happen with a fall, but oftentimes it's with twisting injuries, like using a jackhammer or a drill bit or whatever it is you're doing your DIY at home. So the pain obviously is going to be located in the ulnar side of the wrist. It's increased with obviously movement, especially with twisting or side to side movement or weight bearing. So you might see swelling. Oftentimes you hear clicking with movement, and that clicking is a sign that that cartilage is probably damaged, and obviously you're going to lose grip strength. So make sure you measure grip strength with a dynamometer at the very beginning. This is a really good objective way of understanding how your patient's recovering as well. There are some orthopedic tests. There's an axial loading test that's commonly done for this, where you place the wrist in different positions and you load up and apply axial compression and see if the patient jumps and gets all mad at you, and then you confirm that that's probably what's going on there. The other type of ligament sprain I'm going to talk about is a scapholunate ligament injury. So this diagram on the right, the scaphoid has been removed, and you can see the articulating surface of the lunate where it would articulate with the scaphoid. And then you see this ligament that wraps around and attaches a lunate to the missing scaphoid. And it's kind of like a U-shaped ligament. It has 3 sections to it. The most prominent section is a dorsal section. It's the thickest as well section, and it has an intrinsic and extrinsic fibers or layers to it. Then there's a proximal layer, and then there's a volar or the palmar layer as well. So it's a dorsal compartment that I mentioned is the most important biomechanically, and as I mentioned, it's quite thick, so it has sort of internal and external portions of this ligament. And depending on which those parts of those ligaments are injured can determine the severity of the actual injury itself. So the role of this ligament is to support, obviously, the scaphoid and the lunate articulation, because this articulation in particular serves as a proximal foundation for movement and stability at the wrist. So when you have tearing or a sprain at this area, the scaphoid will flex and the lunate extends, and it can form a gap between the bones. It's not uncommon to get a hairline fracture of the scaphoid as well during this. I personally had this injury along with a fracture. I played basketball in high school, and I was undercut going in for, I'm sure it was a big dunk or something, and I landed on it, my hyperextended wrist. I thought it was a sprain, and it can present as a sprain so easily. And it wasn't until a couple of years later that, because it wasn't healing up very well, that I had an X-ray, and it was an actual fracture that eventually I needed surgery for. And that's what you want to avoid. So make sure that if you suspect at all a fracture, and sometimes it's a good idea to get an X-ray just to rule out a fracture. And the thing with X-rays is that if it's taken right away, you may miss the fracture. It's oftentimes missed. So a follow-up X-ray may also be required as well. So, these injuries to this ligament, it can be anything from a very mild kind of sprain all the way to something more serious like I had, where I had complete tear, and maybe other ligaments around the area are also torn. And of course, I mentioned about possible fractures or maybe even dislocations. Lunate is a commonly dislocated wrist bone as well. So this type of ligament has 4 categories of tearing: pre-dynamic, dynamic, static, and scapholunate advanced collapse. So that's from mild to severe. The pre-dynamic is just an occult mild sprain. You can have normal X-rays, the best prognosis, obviously. In the dynamic injury, the ligament is more completely torn or stretched to the point where it doesn't provide proper support for that articulation. You may also see some mild injury to adjacent ligaments. X-rays usually tend to be negative, but when stressed in the X-ray, then you can actually see a gapping between the scaphoid and the lunate, which shows that there's instability. In a static injury, the ligament is completely torn, so there'll be some gapping between the scaphoid and the lunate, and usually surrounding ligaments may also have sprains as well. So In the most severe form called a slack injury, which is a scaphoid lunate advanced collapse, the ligament's completely torn. And this is more of a chronic scenario. So it's been there for a long time. Now you're starting to get arthritic development, cartilage damage. And when they take x-rays, it looks like there's lots of stuff going on there. So this is really a scenario where if people are coming in, never took care of their injury, and they're talking about chronic wrist pain, that kind of thing, especially at a certain age, then oftentimes this is what you're dealing with, unfortunately. So in general, when you're talking about wrist sprains, obviously there's oftentimes going to be a bit of swelling. So you can compare that to the bilateral wrist, unaffected wrist. Obviously, there'll be a certain amount of pain, especially with movement. There may even be some bruising or discoloration. Usually you can pinpoint tenderness around the wrist itself. And again, have the patient describe or ask if they feel any popping. May even be able to palpate that as you're moving around, which is an indication of either instability and or cartilage damage, right? And you may also, in fact, have some redness or thermal warmth because of an acute inflammatory response. Now, as far as research goes, there's not a ton on ligament healing, and in humans, there's really none. And so I've had to rely more on animal models, but I mean, there are some definite differences between a rat or a mouse ligament in humans, and that basically it has to do with the speed of healing. In rats, as you would expect, they heal super fast. I mean, rats will take over this world, I'm sure, except for in Alberta, where apparently there's no rats, other than just some humans you might know. So, but in the rest of the world, rats are problematic. But now I'm getting off on a tangent. This particular research looked at the medial collateral MCL injuries in rats. So they injured the MCL. They had a way of doing that, and they wanted to compare to see if in fact laser therapy was improving the tensile strength of the ligament upon healing. So 30 rats, they had surgical transection of the right MCL, and then some were in the control group. Others were in a group treated with two different energy densities, a very low one at 0.01 and a much higher one at 1.2 joules. I don't see the wavelength. Yeah, I think it was red, but I'll have to double check that now. Okay, and so then, so some had placebo laser as well. And then they did biomechanical tests at 12 days and 21 days after surgery. This is really important because they're tracking to see what's going on as time goes by. So 30 rats. Oh, I think that's a repeat. Sorry about that. Oh, no, here it is. So it is 10 milliwatts of helium neon. That's just red. So it's around, so helium neon, by the way, was one of the first lasers that they used. It's still used a lot today, but it's actually not a bad wavelength. It's 633 nanometers, so that's red. Now, red you can get away with treating in rats and small animals because these are really small things you're treating, so that light will penetrate into the bone. And you can see here they treated them daily anywhere from 1 second, which would give you 0.01 joules, which isn't very much, and then 120 seconds giving you 1.2 joules per centimeter squared, by the way. These are the results, and it's really interesting. So if you look at after 12 days, now this is the ultimate tensile strength that's been measured. So they have a way of testing this. Don't ask me how they did this. It probably sounds pretty gory, but they checked the tensile strength after 12 days. And you can see here, the 1.2 joules per centimeter squared gave you a fairly high, this is measured in newtons, by the way, and probably newtons per something. It gave you a really much better tensile strength than the lower powered one, and then the sham. So these first three represent an injury, and then treating with 1.2 joules of energy, 0.01 joules of energy, or sham, no energy, and then the control, which had no injury, right, at all. So you can see after 12 days, laser therapy is really doing much better. Now, as you shift to day 21, notice that the other ones are starting to catch up. In fact, the sham is almost the same amount of tensile strength as the laser treated. Okay, so they talk about this in the discussion for this particular experiment. So they did conclude that early on, anyhow, 1.2 joules was significantly improved the strength of the ligament, right? So that's the healing capacity, the collagen formation, and so forth in the MCL. But after 21 days, that effect was not really observable. And what they talked about in this experiment is they basically said, well, you know, more than likely they have to figure out these dosages, right? And understand that, and also how long they treat for as well. So the proof of concept here and the hypothesis was proven, but long-term, you do want to actually see that the laser treatment group had overall better healing than just leaving it on its own as well. And you would see that if they had treated it probably with higher dosages and for longer periods of time, right? As in a human, you don't just treat for a few days or a couple of weeks or whatever. You're going to be treating for longer. So that's going to be providing more and more stimulation. So you should see results in that first 12 days or whatever continue on if you continue treatment as well. And that's what they pointed out to as well in the experiment. So let's talk a bit about wrist fractures. So the figures I looked at, 2017 was the ones I could find the most up-to-date ones, is that the incidence of hand and wrist fractures was around 179 per 100,000 in general population. And that's that figure, 21.44% of all orthopedic emergency room visits had to do with wrist and hand complaints, whether it was a fracture, a sprain, or an injury of some sort. So, you know, that's a fair amount. So looking at fractures of the wrist, there's certain areas that usually where it occurs, usually the distal radius, you know, a fallen outstretched arm. This is usually where it occurs. And it's usually about 1 inch from the actual distal portion of the bone because that's where it's the weakest. So mechanism wise, you know, usually it's on the outstretched hand that usually can cause a Colles fracture as shown in that diagram. But if it's fallen on the opposite where you get flexion, excessive flexion, which doesn't happen as often but can, then this is called a Smith fracture. And the displacement is in the volar direction, whereas the displacement is in the opposite direction for a Colles fracture. Then there's other types of fractures. They grade them type 1, 2, and 3. The way it's shifting, you can see type 1 is no displacement of the bone. But then as you get displacement, you can see the severity of the displacement categorized as a type 2 or a type 3. Usually you require, you know, where they put the bone back in position and or surgery to pin it in place or screw it in place or what have you. I'm not an orthopedic surgeon, obviously. So, you know, they do what they need to do to stabilize it to ensure that it's going to heal properly. Which, by the way, I had a question here earlier, and I'll get to questions at the end, and please feel free to ask me questions. But carpal tunnel syndrome is a common complication of wrist fractures, especially, you know, in and around this area. Especially when it's not treated properly or the surgery doesn't go well, other kind of factors. So I will speak to that maybe a bit about at the end as well. So one needs to be aware of that as well. Now, this is the most common carpal bone that's fractured, the scaphoid. Second most common fracture in the wrist, so the most common is the radius. Second is this scaphoid bone, right? And it's very tricky to identify and to treat. It has to do with the blood supply. There's one artery that travels in the neck. So the scaphoid's kind of shaped like two balls in a thinner neck. And there's a blood vessels that transverses the two little balls of bone. And if the fracture goes through that, it can actually disrupt the arterial, and it may or may not come back to life. And if it's completely displaced, or you have displacement of the bones, then unfortunately what happens is if it's not surgically repaired and you get blood supply back into there, then that neck basically starts to sort of resorb away, and then you're left with two little pieces of bone where there should be one. And that's what happened to me. I didn't know that. So fortunately, it didn't affect my ability to use my hand and all the rest of it. But Surgeons did a good job. They did a bone graft to fix that up. So X-rays are critical. And like I say, oftentimes you will have to do some follow-up X-rays just to double check and make sure there is no fracture in there. The worst case scenario is that there's a fracture and it's not properly managed. But usually in a severe fracture of the scaphoid, it will be observable right from the get-go with an X-ray. So you immediately know that this person needs to be properly assessed by an orthopedic surgeon. So again, I'm just talking a bit about the healing that I've already just mentioned. So as you review for how fractures heal very quickly, you know, initially there's a hematoma, then you start to get the internal callus of fibrous tissue starting to form, and a fibrocartilaginous model with an external and an internal callus, and then you start to get the formation of new blood vessels, and eventually over a period of time you start to get the formation of a bony callus and bone remodeling. So laser therapy accelerates a lot of the stages of bone healing, and it's quite interesting. There's actually been a fair amount of work done on this in research, and ourselves in the clinic, we've treated plenty of fractures, so we've seen really positive results with that. Just some of the research I want to present. This was again on, this one was on animal model, but I do have one on humans. This one was on rabbit tibial fractures. So 7 received low-level laser therapy. Other 7 had a sham control. They used infrared 830 nanometers. As you start to get into bigger animals and humans, infrared is the most important wavelength here because bone is very dense, and to get light into bone is very challenging. So you want to choose a wavelength that's as transparent as possible to get through the tissues. And, you know, there's always debate, and, you know, some manufacturers claim insane depths of penetration. I consistently get annoyed with seeing I won't even say mistruths or falsehoods. I'll just say out and outright lies about things like depth of penetration. So let's be straightforward here, is that light can penetrate into bone, but not really deep. So fortunately, you know, when you're dealing with some of these fractures, you don't have to go too deep, but it's important then that you would treat all the surfaces of the bone to get light in from different directions around the bone to at least try and get light into where the callus is forming as well, okay? So in this particular paper, you can see the specs of what they used. They applied it to the skin, 50 seconds at 4 points only along the tibial fracture site daily for 20 days, right? So every day, 20 days. And then you can see the results here. I'll just pull them all up so we can see. So 2 weeks post-fracture, you can see the laser treatment group and the control treatment group. So right away, you can start to see after 2 weeks, the callus formation doing much better than the control. Then at 3 weeks, you can see the white area is where the callus is compared to the control, one of the control rabbits. You can see still quite a bit of gapping and not really great callus formation. And 4 weeks, you can see near complete callus formation. And in the control, you can still see that there's gapping there. So it's not healing nearly as quickly. So in this particular paper, they concluded that obviously laser therapy accelerates the process of fracture repair, increases the callus volume. They did some cool 3-dimensional pictures. I didn't include them here, but they showed these 3-dimensional pictograms or whatever, showing that the volume was increased. Also, they really did mention that in the early stages, was really critical. So that's really important when you're treating a fracture. Literally, if you're able to get to it and treat it within the first day or two, you really will help your patient accelerate with the healing. This particular one was done on humans, and they looked at closed bone fractures in the human and wrist and hand. 50 patients with closed bone fractures in the wrist and the hand. Some had the laser group and some had the placebo group, again using 830 nanometers. Those of you who don't use BioFlex, that's the wavelength that we use. But, you know, 810, 820, 830, 840, those are all good wavelengths. As you get higher, towards 900 nanometers and above, less absorbed by the target photoacceptors, not as stimulatory. I'm not saying it doesn't do anything. I'm just saying it not as stimulatory. So the consensus is the low 800s for infrared, near infrared, are the best wavelengths. If you want to debate that, then show me all the research and we'll debate it. So they use 10 hertz. Now, this is interesting. So that's a fairly low frequency. And, frequencies is something I'll discuss when we come to our protocol. So just remember that low frequency. They treated 5 times per week for 2 weeks. Here are the results. Before the treatment, you can see VAS, which is the pain. So that's like a 6 out of 10 on pain. The DASH score, which is a questionnaire for functionality and different symptoms, objective and subjective. So the higher the DASH, the worse the scenario. Hand grip strength and finger grip strength. And then the placebo group, which should have roughly the same kind of numbers, which they do. And then after the treatment, you can see the laser group, the pain went down to 3.84. The DASH lowered from 39 to 19, or about 20. Hand grip strength increased about 2-fold, and finger grip strength again increased 2-fold. And the placebo, so no laser, you're looking at a slight reduction of pain as well, which you would expect. The DASH had only a very slight decrease, so not nearly as much improvement overall. And you can see the grip strength as well. Let's see, the grip strength did not really change much, nor did the finger grip strength. I'm just checking, a little bit of improvement there. Then follow-up, so after the 2-week follow-up, again, you can see the pain was markedly reduced in the laser group, and you can see the results for placebo as well, okay? So the results obviously showed that the laser group exhibited significant changes in all parameters compared with the baseline. The results of comparing the two groups obviously found that laser therapy helped relieve pain and improve the healing process of closed bone fractures in the human wrist and hand. So it just goes to show you that there is research to show that this can be very effective. So how does photobiomodulation, I think we're going to go over time again, so but it's going to be another 10 minutes just so everyone knows. How does photobiomodulation affect the bone cells? Well, the research, both mainly in vivo, and some animal model studies have shown there's proliferation and differentiation of bone formation. It increases that, increases osteocalcin, a hormone, and other activities. It increases. Now, these are in vitro, in vivo, and clinical studies. So it's showing the improvement of anti-inflammatory mediators, improvement of functional mobility, improvement of blood supply, blood growth, angiogenesis, proprioception, reduction of pain. So all of these benefits have been shown. So how does it actually work itself? I mean, dealing with bone tissue itself, well, it does heal, but oftentimes up to 10%, there can be delayed or slowed union. And this is really problematic, right? So this is sometimes where the surgeon has to come in and try and deal with it, bone graft or what have you. You don't want to get it to that point. Now, laser therapy can increase the synthesis of DNA and RNA, making proteins to help with bone repair. It can affect the cell cycle regulatory proteins and essentially increase the proliferation of bone cells. So it can upregulate growth factors, these proteins and these genes. It can stimulate osteoblast proliferation activity. It can provide earlier recruitment of inflammatory cells and granulation tissue, as the research I mentioned earlier. So really, the big picture here is it stimulates these, these baby osteoprogenitor cells and causes their differentiation into matrix producing osteoblasts, right? And increases the rate of bone formation and bone ingrowth. So that's essentially what it's going to do directly on the bone, and you need to get the light into the bone. So I'll talk to you a little bit about how to do that. Okay, so when you're treating fractures at the wrist, well, The goal, of course, is to accelerate the callus formation, decrease pain, decrease inflammation, and obviously there's soft tissue injuries as well, usually, so you want to accelerate the healing there as well. The site has to be accessible. You can't do it through a cast. If you're a cornea laser user and they love to show doing laser over clothes and I don't know, they'd probably do over a cast and claim that it treats a fracture. It does not. You have to have the light touch the skin. It has to go through the skin, and your goal is to get it into the bone, right? So the options are removable splint. And by the way, if you're working with a patient and they're at the hospital or whatever, or you maybe, you're on a field and someone goes to the hospital because they were at an event and you were there, recommend a splint that's removable so they can get laser therapy. The only other option, if there is a cast, is having a little access point over the fracture site. They can sometimes cut out so that you can treat with the laser probe. That's the second best scenario. Okay. Right. So Dr. Khan developed some really great protocols for around the wrist. Now, these are used basically for sprains and for fractures, but there are some nuances here. Now, you're always going to start at stage 1. Note the really low frequency. Remember earlier I said low frequency? So 10 hertz, 20 hertz, 10, like around there, that seems to be better. So you may want to stick with that lower frequency a lot before you start to increase the frequency. By the way, when you increase the duty cycle, you're increasing the dosage. So that occurs from stage 1 to stage 2. Notice the long duration, 8 minutes, 10 minutes, as opposed to 6 minutes and 10 minutes. These are for the large dual arrays, not the laser probe. I'll talk about that shortly. So generally speaking, the treatment plan, if you're treating a fresh fracture, you want to treat 4, 5, 6 days in a row if possible. Remember that one research they did 20 days in a row? Well, it's not possible probably, but if you can kickstart it and get it going every day, that's ideal. Then followed up by 3 times a week for probably 4, 5, 6 weeks. It all depends on the type of fracture and the severity, right? You want to do follow-up x-rays to verify there's good callus formation. So that would be very beneficial in seeing what's going on. Then you can tailor off and reduce the treatment to once or twice a week, as you know that things are really progressing well after 3, 4, 5 weeks kind of scenario. I would expect to see healing accelerate by upwards of 40 to 50% time-wise if you use laser therapy as opposed to just leaving it alone to heal. Of course, there's other factors as well, right? Now, where you place the array, it's pretty straightforward. I usually recommend 2 placements, and the two ways of doing it, depending on the array that you have, a really long one or a short one, and or the size of your patient. But usually you're going to approach it where you're going to wrap the array around the carpal bones and the distal radius and ulna. And then I would do a second wrap around at the distal radius and ulna, so just a little bit proximal to that, so there's a bit of overlap to get any soft tissues affected in the area as well. The other option is placing it vertically, sort of parallel to the volar, the dorsal and palmar aspect of the hand, so it's covering the carpal bones and the radioulnar complex as well. So you would do both sides. Okay. Do not apply over pressure. This is going to be a sensitive area. You want to make sure it's stable. So you want to make sure this patient is not bending their wrist or doing any movements or whatever when you take the splint off, right? Because the whole idea of the splint is to keep it stable. So be really careful of that as well. Now, for the probe, obviously, as I mentioned earlier, you want to get light into the bone. That's the idea of a laser probe. If you're not familiar with BioFlex, those arrays that I just did, that's not getting so much into bone. That is treating the blood and the superficial structures and soft tissues around the fracture site. It will stimulate a systemic and anti-inflammatory effect, but that light is not going to be penetrating very deeply into bone. But it will provide that overall effect around the area, which is also really important. And that's one of the differences between our equipment and, say, an equipment where you just have a laser probe or a laser shower. Now, the laser is important because this has a much higher energy density and will get light through the skin and into the bone itself. So the time that you hold over the bone is critical. I'm not going to say hold it for a few seconds because that's not going to get enough light accumulating into the bony tissue. You're going to hold it probably for 15, 20 plus seconds. Okay. I know some people are raising their hand. I'll get to questions at the very end. So hold it for longer periods of time on the bone. Be gentle with it. You don't want to apply over pressure because that might be uncomfortable, but you do want to make sure you're over the fracture site and treat circumferentially around the carpal bones or the radius or the ulna. So from all aspects of that bone, touch the bone, the skin over the bone, and apply it for that period of time. We do have another probe, which is the red probe. So first probe is the infrared. That's the one that's going to drive light deep into the bone, well, as deep as you can get. I don't know how deep it's going to go, but probably several millimeters, maybe a little bit deeper. So you should be able to get it through, maybe up to 4, 5, 6 millimeters. It's hard to say, right? Because there's so many variable factors, but it's not going to go, unfortunately, super deep into bone because it's just too dense. The red probe isn't going to go into the bones per se because of the size of the bone and the skin and the blood, but it will provide an analgesic effect by blocking superficial nociceptors in the area as well. Now, when treating ligamentous injuries, so sprains, same protocol, okay? Treatment plan is going to be laid out a little bit different. Again, ligament sprains are tricky because if it's that fibrocartilage complex that's affected, that cartilage can take a long time to heal, and sometimes incompletely because there's not a lot of good direct blood supply into the cartilage itself. Okay, usually going to start 2-3 days in a row if possible, followed by 3 times a week. And this is probably going to be for several weeks, depending on the severity of the sprain. It may take a little bit longer as well. Remember, if there's cartilage involved, then you want to target in and around where that cartilage is located. That's where your anatomy skill set is going to come into play here, as well as all these different ways of treating. Is you want to have that probe over the sprain or over the fracture. So you better know your anatomy and you better know where these bones are located, right? Which I don't need to tell you that, you all know that. And for ligament sprains, for the probe, you will hold a little bit less, maybe 5 or 10 seconds, because ligaments are more superficial, more easily accessible. Okay, so maybe 5, 6, 7, 8, up 10 seconds per point before you move it to the next one when you're treating the ligaments. So not nearly as long. You don't want to apply too much dosage to one spot because then the Arndt-Schultz principle curve, if you overdo it, it's not going to harm the patient, but the benefits start to decrease because you're overstimulating. Okay, so there's a fine line between getting enough dosage and too much. And that's why if you don't understand that concept, you should be taking training and understand a little bit about how laser therapy works, because it's not just blasting it with excessive amounts of power and expecting a really good result, because that is not how it works. And again, I would use, by the way, I would use the red probe if you have it for analgesia. Okay, wonderful. So upcoming events, next webinar is for the personal therapy system users on safety precautions, cleaning, and basic operation of that. So if you have the personal therapy system, you're welcome to join in for that. And then I have a professional one focused on chondromalacia patella coming up. Both of those are in February as well. Remember, these webinars are always free of charge, and that as long as you register, you will receive the recorded webinar to watch again. This year, we're starting up a series of webinars called Light Up Your Practice. Now, this is these are designed for clinicians that are new to laser therapy. They want to learn a little bit about what laser therapy is, its clinical indications, some of the research, a really good foundation. They're 3-hour seminars. I know it says 9 to 1, but actually it's 9 to 12. I need to update that. The first one's on February the 5th. I believe they're $99. They're not overly expensive. So if you're new to laser therapy and want to learn a little bit more about what it is that it does, and a little bit about what BioFlex is and how it compares to competitors, I would invite you to join in on the first one I'm doing, which is on February the 5th. That's a Saturday morning. It's 9 a.m. until noontime, just so you know.